Want to welcome you all again. How many people are here for the first time? Welcome. We've had a series of several of these seminars, and we've got a few more coming. One of the part of the reason we get you to sign in is so if we need to communicate with you, we can. And it's really important that you do the evaluations because the feedback is helpful. One of the things that the online people had said is that they had problems hearing or cut out, and we've actually replaced the speaker's microphone, and we wouldn't have necessarily known that if we don't get the feedback. So there are other things that we may ask, and we would appreciate the feedback. Anyway, welcome to I think we're the fourth in-person, fifth session of our seminar series for the summer. And today we're going to have Matt Wyatt speaking to us about accessing data in the EHR. Matt has been Assistant Director in the Informatics component for the Center for Clinical and Translational Science, and he also now is working with our new Informatics Institute. So without further ado, we'll let Matt start.
Thank you.
And
So thank you. My name is Matt Wyatt. As Dr. Barner said, I've been associated with the CCTS Informatics and now the Informatics Institute since their inception of each. My background is also in the health system. I've implemented clinical systems for a living, and I've been hanging around UAB since 98 and employed by UAB since 2000. So as Dr. Barner said, today we'll talk effectively about use of data from clinical operations from the electronic health record to support research in basically three parts. One, the overall conceptual use of EHR data at UAB in general for research, the specifics around the environment at UAB, and then drilling into some specific self-service tools to allow you to directly access data to support research at UAB. So to start off, I'd like to show you some of my favorite ICD-10 codes. ICD-10 is the worldwide standard for the classification of diseases or diagnoses, problems. When the United States officially adopted ICD-10 last year in October, there was a good bit of fun had on the internet around the specificity of ICD-10 coding. And it's very disappointing that I only really see one smile in the room. So my hands down favorite is sucked into a jet engine subsequent encounter. For those who have the misfortune of being sucked into a jet engine habitually, but apparently the good fortune to have healed from that at least once. And all of these are real. Some of them are very, very specific, but not really surprising, like bitten by a cow. It is a very common occurrence. It's a very normal thing to document in a probably more rural than an urban academic center. The only one that is not real is the last one, 911.911.911, anxiety due to unrealistic expectations of clinical documentation. That's just one that felt like it should exist for my presentation today. So before I get started, I want to get at least a little bit of idea of who is in the audience. I'm gonna pick on people if people don't volunteer their information. So who currently uses EHR data or wants to use EHR data specifically, and what kind of research do you do? Are you wet lab, basic science research, clinical research, outcomes research, translational research, materials research, not research at all? What is the audience today? Someone's got to answer, or I'll sit here and look at you.
I'm in cardiology research.
So cardiology, clinical research.
I'm in neurology, so I'm clinical and translational.
Neurology, clinical and translational research. Okay? transplant outcomes research. So I look online, and I know Ben is faculty in informatics in the School of Health Professions. Probably more informatics research and qualitative process research, I would guess.
That is correct. Thank you.
There you go. So a couple things to keep in mind as we go through, and this is not progressing very easily. So a couple things to keep in mind as I go through the presentation. One, what kind of data can you get now in UAB? And your perception of that may change from now till the end of the presentation. What kind of data do you want to be able to get access to? And how can that enable your research? How can data from clinical operations enable your research? Whether that's allowing you to do something that you could not previously do, or just making it easier for you to conduct your research. So we're going to do, first I will talk to you about what really is the EHR. What is the electronic health record? And by proxy, I'm going to talk about the Enterprise Clinical Data Warehouse, more or less as if they are synonymous. They're not, but for the purpose of secondary use of EHR data to support research, I may interchange those, and forgive me if you find that offensive, but it is, I'll talk about them somewhat interchangeably today. So what is the EHR? It is effectively the documentation of the clinical process in the application of clinical care to patients. So that could include documentation about things done to the patient, about like prescriptions or medication administrations, procedures. It could be measures about the patient, biomarkers about the patient, whether it is information about a specimen, laboratory tests, a pain score in a nursing assessment, vital signs like blood pressure, etc. It's also process documentation, documentation about how things progress within a clinical environment. So what orders are placed, what order sets are placed, what clinical guidelines have been executed, what clinical decision support rules have fired when there is a contraindication of medications, what the clinician does with that, how often it is overridden and why, etc., when patients are moved from one place to another. So effectively what it is piles and piles of data that is documented in clinical practice by both clinicians, by administrative processes like billing codes applied to a visit in order for us to get paid by insurance, and automatically tracked by the EHR in the process of clinical documentation. So challenges for using that data specifically for research. And this delves into what the EHR is not. The EHR is not research data. It is not heavily controlled. It is not an electronic case report form where you have very strict requirements as to what is and is not documented and how. It is not heavily curated to look at population data. It is there for the purpose of documenting clinical activity by clinicians so that the next clinician who is treating that patient can look at the breadth of information on an individual patient and enable that clinician to take care of the patient. So it is very operational. It is very transactional. It is there's a high acceptance for some ambiguity, there's an expectation that a clinician is going to be looking at the full clinical record at any given time. There is plenty of opportunity for narrative clinical text in the EHR, which is entirely appropriate for clinical practice because that is where a clinician can provide the very detailed, nuanced clinical impression and plan and the things that aren't easily documented in predefined structured clinical documentation. It is heavily variable. So EHR data is messy. It is not that all 900,000 patients have the same pieces of information documented, which is more typical of your 50 patients going through a particular research protocol. Each individual patient is in a different clinical state, in a different clinical process, being treated by clinicians who are documenting very different things depending on where they are, what their clinical subspecialty is. The EHR allows a great deal of flexibility to support 150 plus clinical subspecialties. So it is highly variable. It is very detailed, but it is a different thing than a curated, predefined, controlled research data set. Now I try to warn people or highlight the fact that just because something does not suit a particular need does not mean it is wrong. It just means it was collected for the purpose, for a particular purpose. So when you're looking at secondary use of EHR data, you just have to inherently understand that and acknowledge the purpose for which it was collected and understand that as you decide how it can support your research. So the regulatory framework. So if you ask the question, what data can I get to at UAB? The answer is effectively all of it. UAB is an academic medical center. Research is designated as an appropriate use of clinical data at UAB. It is included in the patient's acknowledgments and authorization for treatment at UAB. UAB Health System has the honor of being sort of designated or tasked or by default the keeper of clinical data, the steward of that clinical data. They are responsible for its safekeeping, its security, its fidelity, its availability, etc. When it comes to what data can be used for research, when and how, the health system offers that or responds according to the IRB. So the IRB determines what is acceptable use of human subjects data, what is acceptable human subjects research, and is responsible for the protection of human subjects. So basically, if the IRB says it's okay and you can access data in clinical practice, then you can access data in clinical practice. After that, it just becomes a matter of logistics of how you get to that data or how that data gets to you. So from a regulatory framework perspective, any data within clinical practice can be approved by the IRB for human subjects research or indicated by the IRB that it is exempt and does not constitute human subjects research and can be used for non-human subjects research. So why do we care about the EHR at all? Why not just go do randomized control trials, recruit patients, and do things completely independent and don't even worry about the EHR or that clinical practice going on? The easy answer is data. 900,000, almost 1 million patients seen at UAB since 2010. Billions and billions of data points. It is incredibly broad, incredibly deep, and it is much, much more data than not only any individual research protocol, but all the research protocols at UAB put together. There is more content, more data available from clinical practice than there is from any research data set. So why we care about that is where there are opportunities is for secondary analysis of data where you either don't have the time or resources to do a randomized control trial for every individual thing that you're interested in. We're never going to have the resources to really do a controlled clinical protocol for everything that we have of interest. So how do we decide? So you find patient populations. You look for patterns in clinical practice. You better target what you're looking for based on some preliminary data in the real world on clinical practice. So it is also typically a much broader population than any individual clinical protocol. So a clinical protocol may tell you a good deal about how a medication affects a white male between 18 and 43 with no comorbidities. That's not reality in the general population. So replicating research findings in clinical practice or looking in clinical practice data to validate allows you to move from small populations to larger populations and outcome research to population efficacy sort of research. So I'm a diagram person. I took probably only about a quarter of the diagram that this goes in, but I couldn't stop myself from putting it in. So generally what we're going to be talking about today, you'll notice this is our electronic health record, Cerner or Impact. Here's our enterprise data warehouse, which is where we stage data from clinical practice in order to make it more available for secondary analysis, whether operational or for research. And then we're going to talk a little bit about I2B2, which is a specific self-service tool that can serve in various places to support the research enterprise. And we're not going to talk about these, but I just want to illustrate that while we're talking about an individual tool today and an individual use, it's really part of a larger structure where this sort of data can facilitate cross-institutional research and networks like Trinetics and our Southeast Consortium or our CCTS partner network, and can also support in different ways more subsetting of data and providing data for individual research protocols or for individual registries, etc. So when would you use EHR data to support research? So the first is feasibility assessment. So in the preparatory to research space, when we ask ourselves the question, do we have a patient population to support this study? When a study sponsor approaches us and says, how many people can you recruit to this study? How many people meet these eligibility criteria? Guessing is not the right way to do it. And the reality and practice at UAB is a lot of times people guess. It is very common for people to guess. So a place where we can really effectively use data from clinical practice is to at least take a first pass at how many people meet at least some of the eligibility criteria so that we can really get a better idea, do we really have the patient population to support this research? Also in developing research proposals, if you have a particular population of interest, you can get additional information about that population, age, race, gender distribution, etc. So when preparing a proposed enrollment section of a grant, you can get a little bit of additional information about a specific population. So say, in my example, white males with 18 to 34 with, I don't know, type 2 diabetes. And you can see exactly what the distribution of within that population is. Study initiation. So in addition to putting up a poster in an elevator or a hallway, that may find you some patients, but you can also get contact information for patients who meet certain criteria and pick up the phone and call them. You can get contact information as well as information about when they will be in clinic. So you can approach your population of interest in a much more targeted, much more effective way, so that you're narrowing your audience to the ones that are most likely to be of interest to you. And it's particularly important when we have studies for which the eligibility criteria are very, very specific and the anticipated population is very low, and you really need to target who you want to pursue to potentially enroll and screen in a research protocol. During the conduct of a study. So in the case where that is secondary analysis, data from the EHR, data from the EDW are the full data set. It is your source of data for secondary analysis. Lock, stock, and barrel, it is the place where you get data for secondary analysis research. If you're doing prospective data collection, doing detailed case report forms, detailed clinical study visits, That doesn't mean you still can't find value in also getting additional information about your patient population from clinical practice. You're only going to be able to ask so many questions in a study visit, in a series of study visits for a protocol. There's a good deal of information, whether it is all of the medications, all of the diagnoses, all of the lab tests for a particular research population. So if you want additional clinical information on every patient who is enrolled in your protocol, no problem. And especially if part of your protocol is going back to the EHR and finding the lab tests and having someone transcribe those lab tests. There is a better way. You don't have to go do manual chart review for everything when it is stored in structured data in the EHR. That can be something that's provided in a more systemic way. And the last sort of when to use EHR data is a little bit different. So for a long time, it could be very easily said that you can't just go in the EHR and go exploring and trying to figure out your hypothesis or test your hypothesis or explore and try to find something interesting. The tool that we're going to sort of drill down into today, I2B2, really does sort of let you do that. It's a set of data that is staged in a way where you really can do hypothesis exploration. The information is acceptable to navigate and use preparatory to research, and it really is a place where you can go sort of refine a question, refine a research question, and really explore potential hypotheses. How? How is really the bulk of what we're going to talk about today. And so there are a variety of ways to get access to clinical data to support research. One that we're going to talk about today is a self-service application that allows anyone at UAB to actually go log in and see a subset of clinical data from the EHR. So I won't go too much into that, but we'll go pretty deeply into that one. The second is via consultation, via Honest Broker, whether that's the Informatics Institute or the CCTS or the Enterprise Data Warehouse team. If you have a question, need data, IRB says you can look at the clinical record or get data from the clinical record. It is come to us. We can answer just about any question that you come to us with. Whether that is specific data exports out of the EDW or I2B2, or if it is information that is in clinical text and is sort of unstructured or semi-structured narrative information, we can go find concepts, find content from clinical text and provide that as well. And not all information, as I said initially, is in structured data. So if nothing else, if you are going to do chart review on a set of patients, while we may not be able to find everything, like how many patients are willing to take 12 tablets every day for the course of a study, that's not documented anywhere. It's not documented in clinical practice because no clinician ever had need to ask that question, absent in the protocol. There are some things that are evident within the clinical record, but not really in a piece of structured data. So in cases like that, while we may not be able to give you a specific list of patients who meet all criteria, we may be able to narrow it down from tens of thousands to 1,000, or from 1,000 to 100. And then target who you make that effort to go do chart review on for additional scrutiny after they go through iterations of meeting criteria that we can assess electronically. So I left a few slides in here about feasibility assessment, study initiation, and data collection for reference, but I'm not going to go through those. Before I go more specifically into I2B2, are there any questions about the general idea, the concept, or the environment within UAB on using electronic health record data to support research?
How far back does I2B2 go?
the question was, how far back does I2B2 go? So the Enterprise Data Warehouse at UAB goes back effectively to 2010 and forward. There are patients who go back much farther than that, but sort of that's a watermark, and that's specifically the implementation of the inpatient electronic record at UAB. And I2B2 represents all of those patients. So it is fed from the Enterprise Data Warehouse on a regular basis, and we maintain the same set of patients as the Enterprise Data Warehouse in I2B2.
Before 2010, there was data in Horizon, and a lot of that data has been exported in Impact, like you can see labs and
Right.
their radiology and stuff. Is that accessible?
So I'll try to, for the folks online, so there's a question about the ambulatory EHR that predates Cerner and called Horizon. And there is, that has been a way to represent narrative clinical documentation as well as things like lab tests and connections to imaging, et cetera. So lab tests replicate in the EDW from exactly what's in Horizon. So every patient you can see in Horizon that has lab tests, you can see in the EDW, exists in the EDW. Much of the information in Horizon was that narrative clinical text. That's not in the Enterprise Data Warehouse per se, but the service functions that the CCTS and the Informatics Institute provide use the same document repositories that feed Horizon or that are behind Horizon. So effectively, we have the same set of information that exists in Horizon. Okay, so I2B2, so we're going to drill down just a little bit more into I2B2. So first is the intended use. So I2B2 falls in that feasibility assessment stage for the most part, simply because it is not all data from the EHR or all data in the Enterprise Data Warehouse. For example, we have a very specific rheumatology clinic note that has specific disease activity measures, tender and swollen joint counts. That is very valuable to rheumatologists at UAB, but is not terribly valuable outside of rheumatology at UAB. So what we have targeted is really the things that are of the broadest value across the entity and across the research enterprise. So as such, it may not answer very specifically. You have to go every question. So there may be times where you go from feasibility assessment in I2B2 and then back into the EDW for more detailed questions. But the purpose of I2B2 really is a self-service function that anybody at UAB can go to at any time of the day to get an idea of a population. And it'll make a good bit of sense when we get into it. We have actually extended I2B2 to go beyond just aggregate data to provide the ability to download limited data sets. So I2B2 does not have full protected health information. It doesn't have name, medical record number, encounter number. We do not make those visible within I2B2. For any individual patient within I2B2, we can track that back to a real medical record number patient and provide that via consultation if the IRB says it is okay. But because we have gone through a process of sort of automatically exempting data that you get from I2B2 from IRB review, IRB is good with that, for the record, it does not have full PHI. What it does have is the ability to download patient data that does include real dates, that does including dates of birth, date of visit, diagnosis dates, dates of individual lab results, etc. And you can actually download patient-level data in order to do secondary analysis. And those are automatically exempt from IRB review. And then the last thing is facilitating the consultation request. So in the case where you need more data, or instead of starting with a completely blank sheet of paper and say, I need all people with diabetes, you can go through a process of narrowing down that patient population and having a good solid set of patients that are of interest to you, and then from there move into the more consultation arena. It can greatly improve the ability of, or the speed in which you can sort of refine the research question. So what is in I2B2 and what is not at UAB? So organizations that are included: UAB Hospital, Kirkland Clinic, all of our specialty and primary care clinics such as Acton Road, Hoover, etc. UAB Highlands, Women and Infant Center. Effectively, it is all inpatient and outpatient data at UAB. What is not included: UAB affiliates in Huntsville, Montgomery, Mobile. It does not include Callahan Eye Hospital. It doesn't include Children's of Alabama or the VA, given that those are separate legal entities. Though UAB School of Medicine faculty practice there, those are separate legal entities. While there's opportunity, there's also not currently any CTSA partner network or CTSA Southeast Consortium data available within I2B2. I think those are going to be things where I2B2 might be a path to facilitating those research opportunities. At present, it is only UAB proper data within UAB's instance of I2B2. So the kind of data that's in I2B2, the categories of data. So patients, we have 900,000 plus patients, 11 million visits, and those are every visit to UAB, including inpatient, outpatient, emergency visit types, specialty visit types like infusion therapy, labor and delivery, etc. If the visit happened at UAB, it is in there. Clinical diagnoses and problems, those include both clinically documented by a care provider in Cerner, as well as administratively coded and applied to the visit for billing purposes after. So it includes both of those things. One reason I try to point that out is this is an example where you have to understand the purpose of documentation. One of the purposes of documentation, documenting diagnosis codes, is for the purpose of getting paid. So just because you have a diagnosis code for cancer does not mean you have cancer. It means that you are being evaluated for cancer and have a visit for which we were evaluating you for cancer, for which UAB wants to get paid. So that is a good example of how you need to understand and consider the purpose of documentation as you are beginning to do secondary analysis of EHR data. Yes?
When you list out the organizations there, what differentiates Women and Infant Center from the rest of UAB hospital? I guess
nothing.
I see it as just another building like the NFS Powell or whatever, but clearly delineated it from UAB
right.
hospital.
Right. So the question is, what is the differentiation of Women and Infant Center, and why is it separate? It is effectively just another physical location of UAB, as is UAB Highlands. The reason it is in the list explicitly is because sometimes people ask, especially Highlands in the past, if that data is included. So your assertion is correct that, you know, from our electronic systems, that's just another place. That's just another room. There's absolutely no differentiating between one physical location and another, between hospital, clinic, and Women and Infants in Highlands. So lab tests, medications, those are fairly obvious. Medications, we have medication administrations, medication prescriptions, and also indications of medications provided by the patient, as in they walk in the clinic and say, I am taking X, even if it was not prescribed or administered by UAB. Administratively coded procedure data, vital signs. The cancer registry data is not actually sourced from the EHR. That's a separate system that is there for the purpose of retrospective, regulatorily required reporting for cancer cases, and we get data from there as well and populated into I2B2. very, very valuable for finding populations of patients based on the abstracted data in the cancer registry. It gets much more detailed about staging and grading of tumors, locations, etc. Much more detailed than diagnosis codes. DRGs, which are a billing artifact that can be very indicative of particular diagnosis and classes of diagnoses, and then allergies, including drugs, environmental, etc. Any questions about that sort of general overview? Because I'm more than half an hour in and we haven't gotten to the demo yet. Yes?
We have is there a data dictionary for all of this?
For this, there is not necessarily a data dictionary, though these are based explicitly on standard encodings. So diagnoses are ICD-9 and ICD-10. So we don't, there's public reference to what ICD-9 and ICD-10 codes exist. Lab.
I want to know whether the record contains the smoking status and how much details we capture.
Right. Smoking status is actually one that is in process of being documented currently. And so when we get to the I2B2 demo, some of those things you'll be able to see that the way you navigate the content is sort of in itself a data dictionary for things like that. For others where it's really much broader and much more harder to sort of navigate without a known standard, we try to stay with existing national standards like LOINC for labs, Multum drug categories and drug codes, which is the standard UAB terminology or encoding for medications, that sort of thing. So I think I'll get to some of your questions in a data dictionary. I will say one of the difficulties is there are 30,000 plus unique clinical events documented at UAB. So it is sort of a difficult thing to say, is there a data dictionary that shows the 30,000 different pieces of clinical documentation at UAB? It is a very different thing than the data dictionary for a study protocol, because there are 30,000 of them, more than 30,000 of them. And that is actually one table within the enterprise data warehouse. 30,000 different pieces of clinical documentation that different clinics, different types of notes document and structure data within UAB. That is an opportunity for us to help people navigate that. But we haven't met that opportunity yet. So the case study, I'm going to try to go through this fairly quickly so that we can get to at least a flavor of the demo of the live system. So the case study, did anybody have opportunity to go do the case study in the demo instance of I2B2? Nope, no takers. Anyone online? Okay, so hearing none. The case study exercise effectively asked for looking for patients who had taken a particular set of medications and have a particular diagnosis, particularly because the medication is typically used for a particular diagnosis. And Dr. Berner had an interesting case study in which they had eliminated people who were not, did not have that diagnosis, and it was sort of immediately obvious to her and to me that they're really missing a good bit of the population. So, I don't know, study design flaw from our perspective. So, in the demo instance of I2B2, we basically looked for people with these two medications, both of which happen to be proton pump inhibitors. And there were 13 patients in this demo data set. Very small, only 118 patients in the whole data set, just basically there to play with. And I would notice that in the case study it indicated two specific medications, but there is actually a category of medications called proton pump inhibitors, and if you just look at the two specified medications, there are 13 patients, whereas if you go up to the category, it's 16 patients. If you're intentionally looking for just those two medications, so be it. If you really are talking about the category of medications and just didn't think about the other ones, you're immediately missing 3 patients.
Yeah.
Yes?
And there's nothing that would tell you that you're missing, is that right?
Not necessarily.
Kind of know.
You do. You have to be able to navigate the content and be smart about how you try to construct the question. Because it is, if you ask a different question, you get a different answer. And I'll show sort of the end result. And actually, I think I'm going to go ahead and skip most of this to UAB data. So in our system, we have 190-something thousand patients on proton pump inhibitors and 37,000 patients with a diagnosis of GERD, gastroesophageal reflux disease. So, and this is a good example. So if you were specifically looking for just these 2 medications, I can't see that, omeprazole and esomeprazole, then you have 25,000 patients who have taken those medications and have a diagnosis of GERD. If you look at the proton pump inhibitors in general, you get about 4,500 more patients. So if it's intentional that you are looking at just those medications, so be it. If not, knowing that there is a category of medications is important because it is going to answer the question that you ask. So I'm going to go do an I2B2 demo. And please bear with me here. This is the point of risk where we're going to live data and hopefully everything still works and I'm not timed out, etc. Any questions before I jump in? And good. So this is I2B2. And so there are a couple of specific places where I'll go through and do sort of a general demo. You're not going to get a full understanding of how to use I2B2. This is not an I2B2 training class, just to kind of give you a flavor of what logical kind of queries you can construct here and generally what kind of information you can get. So you have the ability to navigate by looking down, up and down the ontologies, the trees, the hierarchical relationships. So if you are looking for people who are divorced and speak German, you can navigate your way down the tree and sort of navigate the logical constructs of allergies, diagnoses, procedures, etc. And once you do that, you can drag concepts from here where you are finding terms into the query construction panel. And this is where you construct your logical query. And basically what this is saying here is that find me any patient who is either divorced or separated, one or more of these concepts, and speaks German. The other thing you can do, so in our example of medications, it would probably be difficult to sort of navigate the hierarchy and find your way down to proton pump inhibitors in medications. I wouldn't know exactly how to follow the tree down to exactly where those medications are. So you can search for particular concepts. You can search by specific category, and in this case we're choosing medications, and you can either drag the whole category or you can drag individual medications. If you drag individual medications, you are often offered the opportunity to constrain things by a particular value, whether that is the age between this and this, or a lab test over this, or in this case, particular formulations of medications. You can also search by codes. I'm going to do ICD-10 as a good example. So I think it is transition from ICD-9 to ICD-10 sometimes gets me. User error. So here's I'm finding diagnosis codes for diabetes. So you can search by ICD-9 code, ICD-10 code, LOINC code, if it's laboratories, etc. So what I'm going to do now is just look for some saved queries that are titled some good demo queries, because it seems like those would be good demo queries. Here are examples of where you constrain by a value. You can also, so if you want to logically exclude something, rather than saying patients between 18 and 75, you could exclude patients from 18 and 75. So logically you are saying, find me patients who have any of these diagnoses, are not between 18 and 75, and have either of these results, either a hemoglobin A1C over 9 or a BMI between 25 and 45. When you run queries, you have you can also, in addition to just getting a count, so in this particular case there are 22,000 patients, give or take, you can also get a age, race, and gender breakdowns similar to this. So this is very valuable in your proposed enrollment section of a protocol, or if you just want to get an idea of the distribution of a particular patient population.
So for those patients, let's say that you want to search those patients who will come for a procedure.
Yes.
This procedure happens on in-town. Which
Yes.
one do you prefer? By the procedure, CPT code, or by the encounter?
So it really...
Let's say that, like, I was trying to find out patients who have carpal tunnel syndrome who came for nerve conduction study.
Right.
Okay. And I got like 4,000 patients, which I know that we didn't see in our nerve conduction lab 4,000 patients for carpal tunnel syndrome through the last 4 or 5 years. This number is great. So
that's actually for the folks online, there's a question about a particular query and how to best construct, and it's a little atypical because usually it's the response is that's not enough patients, and especially when you were talking about procedures, hearing that that's an overestimation is a little unusual, I think. So it really depends on how things are documented within UAB. So if you know that a particular procedure always results in a procedure code being applied at UAB, that is logically the best way to search for that. Now, procedure data at UAB exists not in our enterprise data warehouse, but in our financial data warehouse. So that is one of the things that we are working to reconcile. The procedure data within I2B2 currently, I would characterize as very light. It is not a full representation of the financial data warehouse procedures as of now. So
you prefer that to be an encounter-based search?
To be an encounter-based search, what you're really looking for if you are searching for encounters are find me encounters with a particular encounter type. And the encounter type is probably, unless you have a particular encounter type for your particular clinic, that's it's not a piece of information that is actually at the encounter level. The encounter is going to say you will be able to limit it to patients who have had an inpatient admission or a one-time outpatient visit or a labor and delivery visit or an infusion therapy visit. So unless your clinical process is that that is a different type of encounter, it's not going to find patients that you have seen in a particular clinic. Also, clinic location is one of the things that represents a higher risk of re-identification. So at present, we are purposefully not putting location into I2B2 because it just does elevate the risk of re-identification in a way that wasn't comfortable for either IRB or health system. Now, for that kind of thing, that's a very easy thing for us to answer. We can tell you every patient who's been to a physical location and then go from there to what other information exists on them. If there are diagnosis codes for carpal tunnel, I think in general it is use as many pieces of information as you believe represent your population.
And that example has been an example of patients who might have been sent to the neuroprotection studies to rule out carpal tunnel, but they don't really have it. And would that be picked up the same way?
Not knowing the details, but in theory, a test being done, a CPT code or ICD-9 procedure code isn't an indication of the result, only an indication of the test.
Well, we wouldn't, in our practice, we will not call it as carpal tunnel unless it has carpal tunnel.
As a diagnosis.
Right,
Yes.
in your practice. But suppose
And-
the primary
and that's-
care,
And that's coding it as carpal tunnel as a diagnosis, not as anything related to the procedure.
Yes, and that's why I was interested in looking in our, like, coded procedure rather than, because if I thought for that from the primary care perspective in that clinic, I would pick those patients who were sent to us suspecting that they have it while they don't.
and that might be what
Also, yes.
Yes, yeah.
That's what I'm thinking, that the 4,000 is what has been suspected to be. And I wanted to like filter those even further. Yes.
Now, if you did it, if you had another indication of carpal tunnel that you could get, and you use both together, you might be able to narrow that down.
And there is a differentiation between something on the problem list in the EHR and something that is a diagnosis in the EHR. A diagnosis being very specifically in our organization something that is encounter oriented and is more of an indication of a reason for visit, something that is happening to you today, i.e. you are being evaluated for carpal tunnel, you get the carpal tunnel diagnosis code. The problem list is much more clinically oriented. This is a long-standing problem for the patient. It is more an indication of existence of condition. So we can actually differentiate between things on the problem list and things that are coded diagnoses. Now that is dependent on clinical practice, because if you go a few years back, that differentiation didn't exist in clinical practice the same way that it does now.
And the problem list is in there too.
Yes.
Could you filter it with time?
For anything that, the question was, can you filter by time? So for any concept here, you can constrain by a date range. So in this case, this is find me patients who have documentation of contraceptive medications. And you can filter that by time or apply a time constraint to that specific group and say so a documentation of a contraceptive medication within the last year. Or from this date to this date. And you can do that for any individual pain here. So one other thing that I want to show, and I'm going to go I'm going to go back and forth between the slide deck and the live demo. Yes, question?
My question is, does the I2B2 analysis to eliminate the possible redundancy that we associated with multiple encounters for different patients?
What?
When patient has multiple encounters?
The end result that you see in I2B2 when you get a count is unique patients. So it is sort of always distilled down to how many unique patients a patient set. So regardless of how many encounters any individual patient has, it is going to be distilled down to the number of unique patients. So understanding that I2B2, just getting aggregate information out of I2B2 will not satisfy all needs. There is the ability to request detailed data for a particular patient set. So if I want, I can select a patient set, say, give me all of the labs and medications, and submit that request. I'm not going to do that now because it's very time variable depending on how complex and how much data, and given we have 1 minute, 2 minutes left, it's not going to come back probably. So understanding that I2B2 does not have all of the information that you could potentially want, you can start with a patient population and say, here are my 500 patients that effectively meet my criteria. Give me all of the information you have about them in I2B2. That is one thing. The other is you can request a consultation and say, here's my starting data set, and now I need additional information. I would like to talk to an EDW analyst and get the 3 pieces of information that I know are in clinical documentation in the EHR, but aren't general purpose enough to have been loaded into I2B2. So if you have a particular carpal tunnel clinic note that has 10 pieces of structured data on it, we can go get the 10 pieces of structured data on all 4,000 patients who meet your criteria, assuming the IRB says it's okay. It's not in I2B2, but we can start with this patient set in I2B2 and then use that as a starting point for working with an investigator to go back and get additional information out of the data warehouse.
How do you implement this form?
So within I2B2, there are sort of 2 areas. There is the find patients, which is effectively the query construction view. And then what we have built is a tool within I2B2 called this patient download and consultation request, where you can either request an actual, and this is real time, this is not consultation mediated. You can request an actual limited data set, patient set, and in real time get a data set for your population of interest. And this is where we've actually gone through the IRB, and this is the place where we're applying this automatic exemption from IRB review. The IRB knows that if you are getting data from I2B2, it is only limited data set. We are tracking that you have gotten this data set. It constitutes we already have a data use agreement on file as a part of you being allowed to log into I2B2. And so that constitutes appropriate delivery of data that is limited data set, and the IRB considers that not to be human subjects research, or at least considers that to be automatically exempt human subjects research. And then for the consultation, you just drag your patient set of interest and say, I need whatever you need. I would like contact information on these patients. Here is my IRB number. I would like to do clinical text mining to find the whatever it is on this patient set. Here's my IRB number, and initiate a consultation.
And you might want to tell them about the forms they need to fill out prior to.
In order to log into I2B2, you must have HIPAA training, human subjects protection training, which is very typical of anyone who is on any research protocol ever. One additional piece of information we need in order to be able to provide those limited data sets for the exempt, for those exempt requests is effectively a data use agreement. It's a one-page acknowledgement of appropriate use of limited data set data in the learning management system, and it literally takes probably 2 minutes to find, read, acknowledge, and you are able to log into I2B2. If you are, yes, the system knows if you've already taken that. Now, if you are faculty, you don't need any additional approval. If you are non-faculty, you will have to have some additional approval. Nobody thus far has asked that has been inappropriate, but the idea there is not everybody who has a Blazor ID really should be seeing even this level of data. So if you are non-faculty, someone has to say that it is appropriate for you to be doing this sort of thing. We are a couple of minutes over. We started a couple of minutes late, so I think that's fair. Any other questions?
So who gave all this diagnosis code, and do we know if physician give the diagnosis, do we have the physician's UP or something to wherever the RD is?
Not within I2B2, we.
For the specialty
within I2B2, we don't make visible the actual clinician that's associated with the diagnosis. In the source data, we absolutely have that information. So we can see the clinicians who are associated with visits. We can see the clinicians who are associated with diagnoses. We can see the clinicians that are associated with just about anything that clinicians are associated with that we have. Now, that is dependent on what is documented in clinical practice. So if for example, the clinician of record on a diagnosis, if whatever clinical documentation happens does not actually affix a clinician to it or a physician to it, then we don't have it. But for diagnoses in particular, if there's a physician associated with it, we absolutely have it. That's one of those things where the I2B2 tool may not be able to provide that information, but that's a fairly easy consultation. Here's my patient set. I would like all of the diagnoses for this patient set, including the clinician associated with each one of them. No problem. Any other questions?
About the medicine information, what kind of criteria or standardization rules have been used to give a medicine category? I know the protein inhibitor. If I want to find the medicine among diabetes, and there are like a category called diabetes medicine.
What UAB uses in clinical practice is called MULTUM. It is a classification of medications. It's fairly flat. There are drug categories and there are drug codes. And a drug could be in more than one category. And so that's how we currently represent all of our medications. We may very well be moving to an additional encoding using specifically NDFRT, the National Drug Formulary that's used by the VA, and RxNorm for drug codes. But what we have is effectively the MULTUM drug codes and the MULTUM drug categories. I don't know off the top of my head if any particular MULTUM drug category exists, but that's what is used in clinical practice.
So the protein inhibitors that you found,
Yes.
that came out of MULTUM.
That is a MULTUM drug category. And the 6 or 7 medications that we saw in the drop-down list were the MULTUM drug codes that are in that category.
Did that category refresh annually?
Probably more than annually. I think medications is one that is updated fairly regularly. But it is definitely updated. Most things like that within the clinical systems are updated on a fairly routine schedule basis. And in I2B2, we sort of follow that lockstep. If there's a new drug code that we don't recognize when we're loading I2B2, we know that, we find it, we put it in the ontology, we represent it. If there's a new drug category, we will see it and represent it. So we stay with whatever is structured in clinical documentation. Anything else? Oh, I'm here and I'm willing to talk to anybody who wants to corner me. I have information here on the screen about how to get to I2B2. The easiest way is to go to the CCTS or to Google UAB CCTS I2B2. And there are places there to both request consultation from the EDW, also information about what I2B2 is, where it is, what's required, and a link to actually go log into I2B2.